we move on to the next talk by Dr. Atul Ursekar. The topic is practical features and the clinical applications of Octa. Let me introduce Dr. Atul, qualified from JS Medical College and KM Hospital for undergraduate and postgraduate specialization, Retina Fellowship from Shankar Nethalaya. Did his Retina Fellowship with Dr. Yanuzzi at Manhattan Eye, Ear and Throat Hospital. Private practice at Ursekar Eye Clinic, Mumbai. Consultant at Yashlok Hospital and the Reliance Foundation Hospital. Teacher and guide to many postgraduate students. And I experienced in using and a keen interest in multimodal imaging. Dr. Atul, please.
Is there a pointer or just use the mouse? Pointer ke liye?
Just send me 2 of your slides on email, on the working of size system, the broad line one and the other one with the 3 red, green and
Next slide ke liye kidhar page down. So good morning everybody, and I'm going to be speaking on OCT angiography, some practical points, both the combination of technology, the advantages, some shortcomings, and where this new method of imaging helps us. So before we begin, I'm sure everybody is not fully conversant with the technology, so a few important points to keep in mind is that OCT angiography means the machine takes repeated B scans in the same location, and what it identifies is motion. And the only thing that moves in the retina is the retinal blood cells, and that's how you get the angiography image. That's 99% of the time. 1% of the time is some exceptions, which I'll show you. And what this means is that a static image, as you see on the left side, is then converted into a dynamic image of retinal blood cell flow. And this uses various mathematical algorithms. They have all sorts of complex names, but effectively you get an image something like this. And there are some special caveats which you have to understand, is that when measuring the flow of blood cells, if the flow is too fast, as in the choroid, or if it is too slow, for example in polyps, then it may not show any flow. So this is an important thing to keep in mind. Also, it's very important that the image must be static in the sense that at the point of capture, because if there is too much movement, you are not going to be able to capture a good image. So there are special tracking technologies which are in the machine, and I'll show you some examples of how effectively that works. So another important thing about OCT angiography is the software. And what the software does is that it segments the various layers. And this is critical in identifying the disease, because effectively what differentiates OCT angiography from all other angiographies is that this is a 3-dimensional imaging. And this is where it stands out as compared to the other methods of angiography. So segmentation can be so important, as you can see here, where the 2 lines which are segmenting are in the wrong location and the lesion is not seen. Whereas if the segmentation is done properly, you can see the 2 lines being well properly placed, so as to say like calipers, the lesion is well identified. And this is very, very important both to learn to do and in the interpretation of OCT angiography. Obviously, being a digital method, another advantage is that it gives you quantitative analysis. I'm not going to go into the intricate details, but basically what it gives you is the potential for perfusion in that area, and this is measured either in the form of vessel density or in the form of perfusion density. And again, I'll show you some examples of how that can be useful. So this is vessel density. But what is very, very important is the quality of the image. As you can see in this chart, if the quality of the image is good, then there's very little what is known as coefficient of variation. So the images won't be different. Whereas if the quality of the image is bad, you are going to get a very poorly interpretable image. So this is very important. You just cannot do a slipshod job of imaging. So let us look at clinical applications. So this is a patient who was diabetic, who had CSME. As you can see on the left-hand side, she has severe edema. And after anti-VEGF treatment, the edema has resolved. And she was reluctant to undergo fluorescein angiography. She also had high BUN creatinine. I think we've discussed that, but there's still some hesitation in doing this. And also, of course, sometimes you have patients who have known allergies to fluorescein. So I did her OCT angiography, and you can see in the center of the retina seems to be well perfused in both eyes, the right and the left. But when moving to the periphery, you can see that there are large areas of non-perfusion. And in fact, in the other eye, one can see that there is early intraretinal neovascularization. So from a patient who would otherwise walk out of your clinic, you're suddenly now considering altering the method of treatment. So this is the importance where OCT angiography helps you to perform tests which you would otherwise possibly not do. For example, even in diabetic patients, a pregnant patient who is diabetic, you may not, or you may hesitate to do angiograms, whereas here you can do it very easily. Also, it has been said that you will not see microaneurysms, and here's a patient with diabetic CSME, and you can see microaneurysms, which are even visible if you take a good quality OCT angiography. What is important here is you can see the full extent of the foveolar vascular zone, and this is where OCT angiography beats any other form of angiography. So this is a very practically important thing to keep in mind. Here's a patient where you can see a fluorescein angiography has been done, and below is the OCT angiography of the same eye. And you can see that this area is obscured because of leakage. The detail of non-perfusion as well as the foveolar vascular zone is far better defined in OCT angiography. So this is a point of practical importance. This is a patient with diabetic CSME with a lot of circinate hard exudates. This is before treatment and after treatment. OCT angiography allows you to see a particular sign which is not available in any form of angiography, and that is called SSPM, that is scattered suspended particles in motion. Now this is a patient in which you can see the edema is quite severe, and this is the superficial layer. You can see the cystoid spaces, but you can see granular material. Now it may not be so well evident in the superficial layer, but if you look at the deeper layer, you can see this particular scattered granular material, which is called SSPM. It's supposed to be possibly due to proteinaceous material or lipid material, and this is not visible in a conventional angiography. Now, what is the importance of that? Particularly in patients who have this sort of heavy lipid leakage, you can see before and after treatment, the edema has reduced, but the SSPM has also significantly reduced. This is in the superficial layer, and you can see the improvement. All this granular material has gone. It is not granular material, it is some kind of exudate which is throwing shadows because of motion. So this is a situation where that 1%, where not RBCs, but some other material is showing a shadow. And this patient then, of course, has complete resolution of the edema. So this is something which is unique to OCT angiography. Also, this is a patient who was diabetic, non-compliant. You can see chronic edema, a lot of cystoid spaces. But by using the quantitative analysis, I could show the patient that both the vessel density, you see the vessel density, the number of red areas which are gradually reducing and the blue areas which are increasing, as well as the perfusion density, where you can see the blue areas are gradually increasing. So you can see the edema may appear to be the same on conventional OCT, but the perfusion as well as vessel density shows how the patient is deteriorating, and you can sort of discuss this with the patient to improve compliance. In branched retinal vein occlusions, just another example, this is the type of image that you would get probably with an FFA, and this shows you the superficial vascular network. But as I told you, OCT angiography shows you a three-dimensional network, and you can see the severity to which the deeper or the middle vascular layer is affected as compared to the superficial layer. So this, in fact, gives you an indication of the severity of damage to the retina which has occurred. Now, here's an example of central vein occlusion, classic hemorrhages and edema. And you can see here, this was before treatment, and this is after anti-VEGF treatment. But you can see that the vessel density has not improved significantly as compared to the baseline picture. And this was 3 months apart, but subsequently 6 months later, despite the fact that there's no edema, the vessel density has improved. So vessel density is another indication of how the vascular flow is improving, which goes beyond just the fact that you're looking at edema being present or absent. And then, of course, we've seen pictures of MacTel where you know the clinical signs on conventional fundus photography, and you are also aware that everything gets completely obscured with fluorescein angiography. So essentially it's just a diagnosis where you're not seeing the disease, but you're identifying it by the fact that there's leakage. Is that timing or? Oh, 1 minute, sorry.
Sir, you continue. We have
Sorry.
enough time.
Okay, fine. So the advantages of OCT angiography is, you can see in this this is where there is no segmentation. This includes all the layers, but the segmentation is done in a color-coded manner, and you can see from the superficial to the deep layer the complete anastomosis of the MacTel. Of course, OCT angiography shines in choroidal vascular membrane. Not only can you identify the membrane, but as you can see here, you can identify the extent and the direction of growth of the membrane. And here's a patient who had choroidal membrane, and after anti-VEGF treatment, you can see the regression. But equally important, the same patient, you can see the regression which is here, and now in the same patient, there is no edema here, but you can see that there is a fresh outgrowth of the neovascular network. And this is very important because in a way it's like pre-perimetric glaucoma. You can actually identify early vascular growth even before fluid occurs. And I would give importance to this because, as I mentioned to you, the importance of the resolution of the scan. And you can see here, this is a 9 out of 10 and 9 out of 10. That means the scan quality is very, very high, and therefore you can give it great weightage in specifying that yes, there is worsening of the disease. On the other hand, sometimes you have a situation like this where you have cystoid spaces, not outer retinal tubulations, but you want to know, is this an endpoint for this patient? And here you can see what is known as a prune tree appearance, where the neovascularization has regressed, and therefore you can say that this is an endpoint even though there are cystoid spaces and no outer retinal tubulations which would ordinarily be used to stop treatment. Then of course there are situations where you have images like this on conventional OCT, which is like almost like a drusenoid PED. And if you were to see these two pictures, they would appear similar. They're two different patients, but in this case, because of OCT angiography, you can identify an incipient choroidal neovascular membrane. Now, whether you treat or not is different, but it will definitely change your follow-up advice to this patient. So this is an extremely important point of practical importance in these type of patients. Then, of course, there are other types of choroidal neovascular membranes, and here, of course, you have a FFA of IPCV. This is a ICG angiogram, but again, in OCT angiography, you are able to identify the BVN. You may not see the polyps, but the BVNs are definitely, and this can be used to follow up patients. This is another patient where you can see severe cystoid spaces in the retina, but one would like to identify what type of choroidal neovascular membrane is this, or AMD is this. And you can see with OCT angiography a clear flow signal in a vertical direction, as well as in the 3D imaging by going layer by layer, you can identify this as a RAP lesion, which will again change the prognosis and your line of treatment. So this is again of practical importance when you're managing patients with CNVM. Now here's another patient where you see hyperreflective dots, intraretinal cystoid spaces, PED, and you see this vertical, strong hyperreflective signal. So is this a RAP lesion? It could be, but by doing an OCT angiography, again, segmentation is very important, as I explained to you earlier. Now here you can see the segmentation has not been done correctly. So what you're seeing is the edge of the PED, and this is an artifact. This is not the SR-NVM. But on the other hand, if you segment properly, you can actually identify that this is a type 1 lesion and not a RAP lesion. And this can be, the presence of the CNVM can be correlated by the flow signal, which is the red dot which you're seeing in the same location as the CNVM. So this is again important because you're able to identify precisely what type of AMD this is. Again, OCT angiography absolutely shines in non-AMD choroidal neovascularization. Just two examples. This is a patient with CR, and this is an ICG angiogram. Very difficult because they have a lot of RP disease, RP leakage. You're not able to identify a CNVM. But by doing OCT angiography, it's again very easy to identify these lesions. The other situation where OCT angiography is very useful is patients with uveitis who may develop choroidal neovascular membrane. Now here again, this is a patient with chronic uveitis, multiple lesions, and this is an ICG angiogram, and you're not able to clearly or precisely identify is there a CNVM or not. But if you do an OCT angiography, the CNVM is extremely well defined. Of course, artifacts are present, but in which form of imaging is there no artifacts? Practically every form of imaging, whether it is conventional photography or with wide-angle photography, artifacts are present. Just a few points. The most common artifact is projection artifact, where you have an overlay of the superficial vessels, but the software allows you to remove the artifacts, and very often just by clicking that, you can remove the artifact and identify the vessel flow in precisely the area that you are segmenting. Then yes, displacement and doubling can cause confusion, but this is an example of a patient with very advanced disease, and this her vision was 6 by 120 and it had reduced to 1 by 60. So even with a vision of 1 by 60, with the imaging technology, with some experience and with some vocal encouragement, you can get excellent imaging. So there are some handicaps, there are some shortcomings, but by improving your technique and by using some external or internal fixation, you can still get good imaging even with poor vision. Hypertransmission can cause artifacts. For example, this may appear to be a CNVM, but if you see that this is an area of retinal thinning and therefore there is hypertransmission, and you can see that it does not correlate precisely with the area of edema. Probably the single most useful method to improve your images as a practical point in any form of OCT is to ensure that you put some form of tear film supplements before you do any form of OCT. And you can see here, this is the right eye of this patient, a very good image. The left eye of this patient had multiple complications, multiple surgeries, and you can see these little reflections which are caused by poor tear film, but by applying a tear film supplement, the quality of the image greatly improves. So the advantages of OCT angiography is that it's fast, it's three-dimensional, it gives you quantitative measurements, there is no need for any injection, patient's acceptance for doing the test and for repeating the test is very high. Then of course you get a layer-by-layer analysis. You can combine it with unfast imaging. There is no limitation of a transit window in the sense if you miss the time, suppose you're doing a conventional angiography and the patient starts vomiting, then you will lost the transit window. And of course, there's no obscuration of the image because of dye leakage, as you saw on the patient with diabetic retinopathy. The disadvantage, of course, is that leakage is not seen. Then it's difficult to identify microaneurysms and polyps, but you can use BVNs and other methods to identify the presence of disease. Artifacts can occur. Loss of image quality can occur if there is a cataract, poor tear film, or vitreous hemorrhage. There is a limited field of view, but that's improving. And there is need for post-processing. So unless you do proper post-processing and segmentation, you will not be able to make a correct diagnosis. Of course, there's a higher capital expense, and there are very few clinical trials on OCT angiography as yet. So we need to get more information from the research side using OCT angiography so that we can apply that information better. Thank you for your attention.
Atul, I would
Thank you.
like to ask a question from Atul and opinion from Anirudh also. When you, first of all, if you are using the forum software, you are able to, on your table, do the correct segmentation, which your technician might not have done. So that's one advantage I see. Second, do you feel by Octa, we are over-diagnosing some cases of classic CNVM type 1 and labeling them very early in the disease as mistaking them for a branching vascular network and putting them as PCV? Do you feel that this phenomenon is there? This is my one question. And my second question is that if you have a dry lesion and you're following up the patient and the patient suddenly deteriorates and you do an Octa, you many times see a membrane sitting underneath. Would you treat this patient immediately or follow him upon Octa? These are my two questions.
Yeah, so to answer the first question, basically, I think the controversy or the debate regarding type 1 neovascularization and BVN is because of the article by Richard Spade, where they mentioned that this is a type of type 1 neovascularization which later on develops polyps. So in either case, the diagnosis is neovascularization. One subsequently goes in the conventional type 1 way, and the other goes to subsequently develop polypoidal lesions.
In any case, we'll be treating them the
Yes.
same way.
Yeah.
But one has more hemorrhagic phenomena. If it develops polyp, one may not develop polyps and not have a hemorrhagic phenomena. So that is the basic. And in Indian patients, it's significant because nearly 55% of the patients we are seeing wet AMD are actually PCV.
Yeah, and to the second question was related to the
Follow-up of
Yeah,
a
so
dry
again, yeah,
lesion.
so-
Patient is going on at 612 with a dry lesion and suddenly it becomes 624 or 636. And you do an Octa and you see a membrane sitting there.
Yeah, so if you have to identify the reason for deterioration in vision. If there's fluid, you would treat. If there's no fluid, then you probably advise a very close follow-up.
I think in the
That's
PNV,
just the answer I wanted. Thank you.
I think that the PNV is a very common condition where we see the membrane in Octa, but in conventional OCT there is no fluid. So I think these are the cases where we need to observe rather than jump into treatment.
Yeah, rather than jump into that. I thought it's a very important message to pass, not to inject, but to watch for a couple of months, monitor the clinical picture and the OCT and the Octa project.
So still, do you do angiogram and Octa together in all of the cases, or there are certain indications where you are doing only Octa?
Since I've also used a spectralis, I do multimodal, but increasingly so I'm doing less and less fluorescein. Because again, as the technology improves, as your ability to do the scan and interpretation improves, as the wide angle Octa
But
comes in.
cases like CSR still needs an DFA to be done.
Yes, especially those who are confounding, who come repeatedly, then one would do a combined.
In
not
fact,
just use Octa.
in fact, I see in my clinical practice as a supplemental angiography, ICG has gone up more, and fluorescein cases in AMD have come down. ICG has improved because I want to see if there are polyps, especially if I see a hemorrhage somewhere or a PED somewhere which I could be extrafoveal and I could just laser it off after a couple of injections.
So we are used to this OCT biomarkers. So I think there are some Octa biomarkers also which will eventually guide the treatment management. So anything you want to say about the Octa biomarkers?
No, as I said, the biomarkers would be particularly useful when they are used in clinical trials, because that would strengthen their importance. So till then, what I would say is that only use those biomarkers where you have got a good high resolution scan, because sometimes you're likely to have mistakes or some artifacts if your scan is not of a good quality. So as I showed you, the neovascularization after regression showed early growth, but I used that as an important biomarker only because the scan quality was very, very high. If the scan quality was, say, 4 or 5 out of 10, then I would probably not give it as much importance.